Scalenus anticus muscle. The anterior scalene or scalenus anticus is part of a group called the scalene muscles. This group consists of scalenus anterior, scalenus posterior, and scalenus medius. These muscles are located on the sides of the neck. It is deeply placed, lying behind the sternocleidomastoid. It is located between the subclavian vein and the subclavian artery. Division of scalenus anticus, without resection of cervical rib. With resection of cervical rib, the physician performs a surgical procedure where the scalenus anticus muscle is divided, usually for the purpose of treating thoracic outlet syndrome. With the patient under anesthesia, the physician makes an incision overlying the scalene muscle. This incision is carried deep to the muscle. The muscle is exposed and identified. A dissection of the muscle is performed in line of the fibers. This relieves the pressure on the neurovascular structures. The wound is irrigated and closed in layers. Division of sternocleidomastoid for torticollis, open operation, without cast application. With cast application, torticollis is a dysfunction of the neck with congenital or traumatic onset. The head becomes inclined toward the affected side and the face toward the opposite side. The physician makes an incision 5 cm long above and parallel to the medial end of the collarbone to access the tendons of the sternocleidomastoid muscle. A blunt instrument is placed behind the tendons to protect vital structures in the neck. The muscle's tendons attach just behind the ear and to the collarbone. The physician splits the tendons further up the muscle to release the restriction. The physician probes the wound to identify remaining tight muscles or fascia, which are cut until full motion is obtained. The physician closes the incision with sutures and strips. Stenosis or stricture. When a tubular organ or blood vessel becomes excessively narrow such that it can no longer perform as nature intended, it is a condition referred to by physicians as stenosis or stricture. Division of stricture of rectum. The physician performs division of a rectal stricture. The physician makes longitudinal incisions in the scar tissue in one or more places circumferentially around the strictured area of the rectal mucosa. A dilatation of the strictured area may be performed. In addition, the internal anal sphincter may be incised as part of the procedure. Plantar fascia. The plantar fascia is the thick connective tissue, aponeurosis, which supports the arch on the bottom, plantar side, of the foot. It runs from the tuberosity of the calcaneus, heel bone, forward to the heads of the metatarsal bones, the bone between each toe and the bones of the midfoot. Division of plantar fascia and muscle, e.g., Steindler stripping. A longitudinal incision is made on the medial side of the heel and is carried distally to the other side of the heel in order to expose the underlying soft tissues. The superficial and deep layers of the plantar fascia are separated from the muscle and fat by blunt dissection. This allows for freedom of movement of the fascia and releases the scar tissue. Once sufficient movement is obtained, the incision is sutured and a soft dressing is applied. Weight bearing is allowed as the wound heals. Aberrant vessel, vascular ring. Vascular ring is an abnormal formation of the aorta. It is a congenital problem.
Division of aberrant vessel, vascular ring. With reanastomosis, the physician gains access to the mediastinum through an incision through the left chest, posterolateral thoracotomy. The physician identifies the two aortic arches and occludes the smaller left arch with vascular clamps. The physician divides the arch and oversews and possibly ligates the divided ends. The physician dissects away the stumps of the divided left arch and frees them from their mediastinal attachments.
The physician attaches traction sutures to the ligated stumps and to the endothoracic fascia anteriorly and posteriorly to minimize obstruction to the esophagus and trachea. The physician closes the remaining surgical incisions and dresses the chest wall wound. The physician may leave a chest tube and/or a mediastinal drainage tube in place following the procedure.
Parotid duct diversion, bilateral, Wilk-type procedure. The physician makes an intraoral incision overlying the parotid duct. The path of the duct is diverted into a new position and sutured to the mucosas so that the opening of the duct is in a different location. To bypass a blockage, the duct may be cut behind the blockage and repositioned so that saliva can flow freely into the mouth. This procedure is performed on both parotid ducts. Parotid duct diversion, bilateral, Wilk-type procedure, with excision of both submandibular glands. With ligation of both submandibular, Wharton's, ducts. The physician makes an incision in the skin of the neck below the inferior border of the mandible. The underlying tissues are dissected to the submandibular gland. The gland is exposed, freed from the surrounding tissue, and removed. The incision is closed with sutures. The mucosal incisions are closed directly. The physician ligates both submandibular ducts. An incision may be made over the duct. Suture material is tied around the ducts to stop the flow of saliva. The mucosal incisions are closed directly. The physician also removes both submandibular glands. Continent diversion, including intestine anastomosis using any segment of small and/or large bowel, cock pouch or cami enterocystoplasty. The physician makes a midline incision in the skin of the abdomen. The end of the small intestine and first part of the large intestine is removed. A stoma is made in the wall of lower belly. The piece of intestine is then connected to the ureters on one end and to the stoma on the other. After shaping the intestine segment into a pouch, the physician dissects each ureter, makes small incisions in the intestine segment, and surgically connects each ureter to the intestine segment. To provide support during healing, the physician inserts a slender tube into each ureter, and closes the pouch. The physician brings part of the pouch out through an abdominal wall opening, or anastomosis the pouch to the male urethra. The physician inserts a drain tube and performs a layered closure. A dissection is a tear within the wall of a blood vessel, which allows blood to separate the wall layers. Usually, a dissection is an arterial wall dissection, but rarely it may be a vein wall dissection, VWD. Dissection, deep jugular node, S. The physician makes an incision over one of 3 jugular groups and retracts tissue. The nodes are isolated and excised. The incision is closed by sutures.